Okay, so now that we've really delved into the theory and defined all of the constructs that are related to self-determination theory, I want to give you some supporting evidence of that theory within the healthcare context. Right? Does this really work? Does supporting these basic psychological needs and trying to foster more autonomous or more intrinsic motivation, does that really help people to engage more in health behaviors and therefore to have better health outcomes? And so that's what I want to provide some evidence on in this section of the lecture. So the first study I want to talk about relates to a really important issue for health psychologists, which is the issue of non-adherence to medication. My apologies, I really always stutter when I say this word, so non-adherence to medication. There we go. And so this is a major issue. So depending on which studies we look at, estimates vary somewhat, but some studies suggest that on average patients only 50% of patients take their medication as instructed. Some estimates say that might be even fewer depending on how we count. So this one study, this is within the US, this came out in 2010, so it's a little bit older now, but haven't seen any evidence to suggest that this has gotten better. But for every 100 prescriptions that are written, only 50 to 70 are actually filled at the pharmacy, and then of those, 48 to 66 is then picked up, 25 to 30 now are actually taken properly, right, where you take it every day if that's what's instructed, twice a day if that's what's instructed, and then when it comes time to refill that, only 15 to 20 are refilled on schedule, right? And so when we think about medical interventions, right, taking a pill is about as simple as it can get, right? All you're supposed to do is take this pill and swallow it. But I'm as guilty as anyone, right? It can be really difficult to remember to do that and to stay on top of your medication. And so this is something that health psychologists are concerned about, right? How can we make it more likely that people stick to their medication regimen, especially for really important issues like chronic pain or mental health concerns, right? You really need to be doing that regularly for the treatment to be effective. And so when we don't take our pills properly, that really reduces the treatment efficacy. And so this study, this is one of the early ones that from SDT that looked at the impact of need fulfillment, and particularly focusing on autonomy, need fulfillment on people's health behaviors. Again, in this case, their adherence to taking their medication. And so this the sample for this was 126 adult outpatients, and so what that means is patients who were not in the hospital, but they were out living their lives, but they needed to take long-term medication. And so this was for issues like hypertension or menopausal symptoms or arthritis, right? So things like that where you need to be taking that on an ongoing basis. And so they, in this case, they assessed the autonomy support of the healthcare provider through a clinical interview, right? So these were the healthcare providers that these patients already had. So, who was their doctor? And the researchers in this study, Williams and colleagues, they went and interviewed those doctors and asked them about their style as a doctor. How do they interact with their patients? What's their way that they go about running their clinic? And so based on those interviews, they assessed how autonomy supportive versus controlling those healthcare providers were, right? The people who were prescribing the medication to these individuals. And so then they followed these individuals over some time, and so they assessed their how much they adhered to their medication schedule in a number of ways over the next 2 weeks. And so they had them report their pill count. So they had them actually count the number of pills that they had in their bottle, right? And so if, because they interviewed with the doctors, they had information about, how many pills were there in a bottle, how many were you supposed to take a day. So based on that, we can calculate how many they actually took as they were supposed to, based on how many were left. And so they asked them this 2 days and 2 weeks after they had assessed the autonomy support of the provider. And then they also just asked them, did you take your medication as you were supposed to? So they just assessed that in 2 ways. So what they found, right, so this is, these are looking at some correlations here. And so we can see that well, first we'll look at the second piece here, right? So certainly people came in with individual differences in their motivation for taking their medication, right? When we think back to the motivational continuum that we just learned about, right? People can vary where they fall on that, and so certainly certainly people bring some of that with them to the interaction with the healthcare provider, and so that was a very significant predictor of how likely people were to report. How likely they were to report that they took their pills. This is their self-report variable, and this is their 14-day count and their 2-day count, right? So there was a very strong relationship between both what they said as well as how they actually took their medication 2 days and 14 days in. So people who were more autonomously motivated, so more to the right of that continuum, were more likely to take their medication as prescribed, and this is quite a large effect size here. But then additionally, right on top of those individual differences, the support from the healthcare provider also was significantly related to the pill counts. It didn't have a relation to the self-report variable. That seemed to be mostly related to people's individual differences in their motivation, but it did have a relation to how many pills they actually took, and so there was a significant effect there as well. This column here at the end is just the average across these three different ways of assessing whether or not they took their medication as instructed. So then the researchers also modeled this in a path model, and this is just showing that the autonomy support from that healthcare provider had a significant relation to the people's own motivation, right? So while people certainly bring some of that with them to the healthcare provider interaction based on past interactions and other sources of individual differences, but also the interaction with those healthcare providers, the type of provider that they were based on those interviews, that was significantly related to the patient's own autonomous motivation, and then that in turn predicted how likely they were to stick to their treatment regimen. And so this is again a latent variable that's composed of the three ways that they assessed whether you were taking your pills or not. So that's again, that was with medication adherence, and so we said that even though that should be a relatively easy health behavior, it doesn't seem so based on the rates at which people actually take their medication. It is a little bit higher in Canada, in part because prescriptions are a little bit easier to come by, but as in terms of having insurance, but as we'll talk about in the healthcare policy lecture, that's not always true. Prescription drugs are not covered under the national health plans. So you have to have a supplemental insurance for that, and so certainly that is one of the reasons that prescriptions are not taken as instructed. But in the study we just looked at, right, everybody did have their medication, and then it was even after you have access to that, people still are not that great at taking that. And so then I want to turn to looking at some other health behaviors and the impact of SDT there, and also moving beyond this more correlational study. Right there, they didn't really manipulate anything in that study. They just interviewed the healthcare providers and got an assessment of their how autonomy supportive versus controlling they were in their practice style. But in this study here by Helvari and Helvari, they actually manipulated the amount of autonomy support provided to patients by the healthcare provider. So this is what we call a randomized control trial here. And so they actually randomly assigned people to two different conditions and looked at the impact of this intervention relative to a control condition on people's motivation and then their dental hygiene outcomes. So in this case, this key question that they're looking at is, will autonomy support from the provider, in this case, a dentist or a dental hygienist, so the person who's you're talking to most at the dentist, whether autonomy support from this provider will lead people to floss more and therefore to have less plaque and gingivitis. And one of the really cool things about this study and about looking at this particular health behavior of flossing is that it's really easy if you are in the dental industry to be able to know if someone has flossed or not. That has really clear effects on plaque and gingivitis and the amount of inflammation in the gums. They know when you're lying. Believe me, tried it, they can tell if you haven't been flossing or if you've just flossed right before you've gone in, right? That there really is a very strong effect of flossing on these visible signs. And so certainly we can ask people about whether they floss, but this is also a way to get a more objective measure from an outside source, in this case the dentist, whether they've actually been doing this or not. And that's also of interest because we certainly care about these outcomes of plaque and gingivitis, not only because of our teeth, but it turns out that these things, our dental health is actually really strongly related to our cardiovascular health later in life. So important to take care of our teeth. So in this study, there were 84 participants in this randomized controlled trial. And so at time 1, they first had people do a self-report measure of their motivation for dental care, right? So first they just wanted to see where they were starting from on that motivational continuum, right? So, where from left to right, from more external or introjected motivations to more identified ones. What was people's motivation for engaging in dental hygiene, in this case, brushing and flossing. And then they also did an actual appointment where they assessed their level of plaque and gingivitis, right? So they went to the dentist and they did that thing where they, poke each tooth and they yell out numbers that, you don't quite know if that's good or bad, and they chart that, and so they can actually get a sense of your level of dental health based on plaque and gingivitis. And then so this whole thing went on over the course of a month, this procedure, this intervention. So then at time 2, they came in for teeth cleaning, right? So they kind of wiped the slate clean in terms of plaque and get a checkup then, so a typical dental appointment that you might have. And then in the intervention condition, they had an autonomy supportive oral care consultation. And what they did in this case is that they began with an open-ended session where they really asked the patient about if they'd had dental problems, what their concerns were about their teeth, and then the hygienist, the care provider in this case, listened really carefully to what the person said and gave suggestions and recommendations based on that. Right. So, for example, for me, it would be, I have to wear a mouth guard at night because I grind my teeth, and I really struggle with remembering to put that in before bed. And so I would, voice that to my dental provider, and I would say, I recently was given a new one that you have to heat up with hot water before you put in, and it's really a pain, and it makes it even harder. I was actually doing pretty well at wearing this for 10 years with my old one, but now this new one really is an extra level of inconvenience. And so then that provider would hopefully say, oh, that's really good to know. Certainly there were some advantages of that type, but maybe we can move you back to a type that doesn't involve that extra step so that that's easier for you to engage in, right? So that could be an example of something that they might do to help you address a concern. Maybe you're concerned about that you're getting more cavities, and they give you some recommendations around that, right? But really with this important piece of listening openly, and then when they're providing these recommendations, really giving a meaningful reason for that, right? So if you're concerned about cavities, not just saying well, don't eat sweets, but giving a really good reason for why maybe you particularly want to steer clear from soft drinks because, not only are those bad for your teeth, but they're often things that we might sip over many hours, and so then sit on our teeth for a long time. Or maybe they recommend that, because you really like your soft drinks, maybe rather than cutting them out entirely, they recommend that you brush your teeth afterward, or there's some certain types of gum that can really help to cut that acid, and so maybe they recommend something like that, right? So this is just examples of what, again, autonomy supportive care could look like in this context. So they get that type of intervention. And then the other group doesn't get an intervention, so they don't get this autonomy supportive time. They just spend that time getting just general, information and facts about, you should brush and floss. So they got this checkup a month later. This happened immediately afterward, and then 7 months after that, right? So usually it's about 6 months between appointments. So so this is 6 months between those times. 7 months since we started the study. So 6 months later, they bring them back to the dentist office, and now they assess again their levels of plaque and gingivitis, as well as, again, they assess where they fall on this motivational continuum for engaging in dental hygiene, right? So what's their type of motivation again? Is it interjected? Is it more identified or internalized? And so hopefully if you've had an autonomy supportive care provider, right, you would have moved more to the right of that continuum. You would have had your basic psychological need for autonomy met and therefore become more autonomous in your own motivation for engaging in this behavior. And so this is the first piece of information that we're looking at here in this graph is first, like, did this intervention work in terms of did providing people with autonomy support lead them to become more autonomous in their motivation. And so you could sort of call this a manipulation check in that way, but it really is more than that, right? It's that first step in our model of does basic psychological needs support predict people's own motivation. And so what we see here is first at time 1, in blue is the control group, and red is the SDT group. Sometimes random assignment, right? It is random. It doesn't always mean that the groups end up equally initially when you randomly assign people to those groups, and that's something that happened in this case. It wasn't quite a significant difference between these groups, but just by chance the control group actually started out more autonomously motivated for engaging in dental hygiene. That's not a problem for us. That's actually in the opposite direction of the effects that we expect. So if anything, we're just getting a more conservative test of our hypothesis. But also what we're really interested in is, right, did individuals themselves change? Did people move along that continuum? And so when we look at the SDT group, they started off with fairly moderate levels of autonomous motivation. And then at time 3, at this 7-month later period, right, so after this intervention, they were significantly more autonomously motivated, right, moved to the right overall on that continuum in their motivation for engaging in dental hygiene. Right, so this is a significant difference there between the 2 red bars. And then also by this time 3, there was a significant difference between the control and the intervention group, such that the intervention group was significantly more autonomously motivated than the control group. And so, so this is really strong support for autonomy support as a means of getting people to become more motivated, or at least to report that they are. But then, did this really work in the sense of did people actually, then floss more? They might be saying they really value flossing, but are they doing it? That's what the dentist actually cares about, right? And so then we can look at these dental health outcomes, right? So these are people's levels of plaque at time 1. They're pretty high on this chart, and there's no difference between the control group and the intervention group. But then at time 3, right, they've gone down for both of them. It's not significant here. This blue bar is not significantly different than these ones, but the SDT intervention group has significantly less plaque than both the control group at time 3, but also than they did at time 1. And so again, this is a significant effect and shows that this was, effective in getting people to floss more and reduce their levels of plaque. And the same pattern of effects was found for gingivitis, no difference at time 1 and at time 3, so that's 7 months later. People in the SDT intervention group had significantly less gingivitis than in the control group, and then compared to the 2 groups when they started. So, but again, flossing, again, as health behaviors go, is considered to be one of the easier ones, maybe not quite as easy as swallowing a pill, but again, I'm not saying these things are easy, I also struggle with them, but compared to some of the more sort of challenging health behaviors that involve, lots of cognitive steps, right? So maybe, trying and also have some addictive properties to them. So quitting smoking, might be more difficult than that, or trying to manage your diabetes or engaging in diet and exercise, right? There might be a lot more steps to that. It's not quite so straightforward what you need to do, whereas flossing and taking a pill, again, not always easy to stick to those regimens, but a more straightforward behavior, and also doesn't have, like smoking, an addictive property to that behavior that makes it extra difficult to change. So it's great that SDT works for these, easier behaviors, but does it work for these more difficult behaviors, right? So I want to just speak to a couple studies that look at that. So getting people to quit smoking, and again, managing diabetes and diet and exercise, and so different types of weight management. So first, a study that this is a clinical trial to help people to quit smoking. So again, a randomized controlled trial, so similar type of study to the last one, where there's an intervention group and a control group, but this time in the domain of quitting smoking. And so in this study, their sample was just over 1,000 adults who smoked more than 5 cigarettes per day, right? So these are smokers, like fairly heavy smokers. And in this case, there was a community sample, and they were mostly relatively low SES individuals. So it was a working class sample in this case. And one of the things that's really interesting and important about this study is that you didn't have to want to quit smoking to be in this study, right? So this was a study where they were paid fairly well to be in it, so they got a lot of interest from people who were smokers but may or may not have wanted to quit, right? When we think back to our model of looking at the different stages that people might be in thinking about their behavior change, right? These people might have been in pre-contemplation or in contemplation, or really may have been in the initial steps of taking action to try to quit smoking. And so they had people across the range of that, right? So they're working with a difficult sample. Some people don't even want to quit smoking. And so then they randomly assign people again to one of two conditions, an SDT treatment condition, and then their control condition, which they called a community care. And in this case, they basically got a pamphlet and a list of resources that the community has to help you quit smoking, right? So different AA type groups for quitting smoking, and also encouraged to talk to their primary healthcare provider. So really not much. And then the SDT intervention group, they met with individually with clinicians, physicians who talked to them about their smoking behavior. They asked them, why they smoke, why they're interested in quitting, or why they're not interested in quitting. Really, again, listened to that, and if they were interested in trying to quit, they gave them information and suggestions and strategies to work on that, including access to medications that can help you quit smoking, like the patch or nicotine gum, things that are tools to help you overcome that addictive part of this health on behavior, right? So again, did this step of really listening, giving information to support autonomy as well as competence, but also really giving a rationale for that, right? Not just saying you should do this, this, and this, but giving reasons and rationale, and taking the patient's perspective around this behavior that they're trying to change or not trying to change. So then, they compared this to the community care condition. So I already said this, but they asked them about their smoking behaviors. They asked them if they wanted to quit, and only then did they give them this information and resources and medication. And so the question, the key goal, or the key question in this study is: can information that's presented in this autonomy supportive way help to build that competence around quitting smoking? A hard thing to do, right? A pretty overwhelming thing to undertake. Most people who do quit smoking, they go through the quitting process multiple times before they're ultimately able to do that. Again, this is not everyone, but it is a difficult thing to do. And so, again, looking in this study, so initially there's no baseline differences in intention to quit. They randomly assign these to these two different conditions, and there's no differences in their intentions to quit. Their self-report of where they fall on that motivational a continuum, and there's also no difference in their competence or their sense of that they have the resources that they need in order to quit smoking, right? So there's initially no differences between these two conditions, and then after 1 month, where the intervention has gotten these interviews, the intervention group reports more competence and more autonomous motivation for quitting smoking. And then they also looked 6 months later. And so looking here, what they found is that, so they looked at a couple different things, and one of the things they were interested in is whether people used the nicotine medication that they were provided, right? This is one of the thing that can really help people to quit smoking, is to use this in a strategic way and to use it regularly. So this is sort of one of their outcome measures of whether people were indeed working on quitting smoking. And then they also looked at their actual abstinence over 6 months. And at first glance, these numbers might not look that impressive, but they actually really are, especially when you consider that, right, we started with the sample where people may not have wanted to quit at all. right? So some number of people didn't even really engage with this information in the first place, and they're included in these estimates. Right, so in the community care condition, right, so about 16% of people used the medication regularly, used it 6 days. They did a count of that, and they after 6 months, less than 4% of them, had been effective in staying abstinent from smoking, right? So not smoking. Whereas in the SDT intervention condition, right, just over 30%, or more than twice as many, or just about twice as many, took the medication to help them quit smoking. They used it for more days, and 11% were still abstinent at 6 months, and so that's about 3 times more likely to have quit smoking, right? And again, that's only 11%, but we're including people who didn't even want to. And again, this is a hard thing to do, and so really just having this one interview with this provider really made a difference in people's motivation for engaging in quitting smoking, and then their ability to do that. Then another study I want to talk about, again with difficult behaviors. This is the one that you read for this week. Here, this was a 1-year-long weight management program that was focused on diet and exercise. And so in this study, this was 208 women who were participating in this. And again, this is a randomized control trial, RCT, and so the intervention group, this again was based on SDT, and they there was a number of things that they did to fulfill these basic psychological needs, right? Building sustainable knowledge, that's competence, encouraging choice and self-initiation, autonomy, providing options, autonomy, clear rationale, autonomy, connecting goals and lifestyle, that's also autonomy, but also competence, right? Really linking the things that you're doing with what's going on in your own life, building efficacy around that. Also providing positive informational feedback, right? How are you doing, helping you to track and get a sense of, are you being effective at these goals? And so that's an important piece as well that supports competence. Whereas the control group got more standard information, right? Tips about, types of exercise you can engage in, some, on nutrition information, healthy diet information, and so importantly, they got about the same amount of face-to-face contact of 30 sessions, right? This was quite an involved intervention, but this is important, right? So that it's not just the effect of, showing up to this thing regularly. That will be driving the effects, right? We can compare the intervention group to a control group that had just as much time and effort that they put in to this work. So what did they find? I mean, they found a number of things, but some of the key findings were that participants that were in this SDT-based intervention condition, they reported first that they did indeed perceive more autonomy support from their providers. So they actually, the training for these providers to be autonomy supportive worked. They were indeed perceived as such. And this led to more intrinsic and more identified self-regulation for exercise, right? So more people were in those two rightmost quadrants of the, I guess it's not a quadrant if there's not 4, but 2 rightmost slots in the motivational continuum, right? So intrinsic and identified self-regulation for exercise. They also were likely to engage in more exercise. They took more steps, really a significant number, more than 2,000 more steps per day on average. That's probably more than I take now that we're in quarantine, in a week, let's be honest. I need to work on that. They engaged in more minutes of physical activity, 138 more minutes. Again, that's per week, so that's a significant amount as well. And they also we'll see a graph of this in a moment, but they also lost more weight, 5.6 kilograms of body fat versus negative, versus the other group actually gained about 1.5 kilograms, and this was a significant loss in percent of body fat, about 7% body fat that they lost as opposed to actually gaining a little bit in the other condition. And so, yeah, their BMI went down overall in the intervention condition. All right, and so just looking at these, these results are somewhat complicated. Right? So here what we're looking at is 4 months after this intervention and 12 months after this intervention. What's the difference between the intervention group and the control group? And here we're looking at multiple of those pieces of the continuum, different steps along the continuum. So we've got the external, the most to the left, then introjection. Then in this study, they really combined, identified, and internalized, and so we just have one there, and then we've got intrinsic. And so first I'll start with the more straightforward of the results, and then I'll talk about the more complicated one. And so first, both at 4 months after the intervention and 12 months after, the intervention group was more identified in their motivation or self-regulation for exercise, right? More likely to say that they really valued that it was important to them, compared to the control group, right? So there's significantly more, and so that was true after the intervention, right? Remember, they started with no difference here, and then that maintained for the 12 months. And the same pattern was found for intrinsic motivation, that was greater for this intervention group relative to the control group after 4 months, and that they maintained that greater intrinsic motivation 12 months later. When we look over at external regulation, there really weren't any significant differences there across the two groups at the two time points. And then most curiously is what happened here with introjection, right? That what we see is that actually the intervention group had more introjected regulation at both 4 months and at both 12 months compared to the control group, right? And that's one of the bad types of motivation, right? Where you feel like you're doing it because you should or you have to. And we see that they do have more introjected regulation compared to the control group. At both these times, but in both groups it's going down over time, which is a good thing. Right? They're becoming less and less introjected. And so the authors unpack this a bit and talk about it, and they don't have direct evidence to this in this study, but they suggest that one of the potential reasons for this counterintuitive effect is that there's more introjection in the intervention group because more of them are moving through these stages, right? They're moving from external regulation through introjection, and so many of them enter that stage, especially at 4 months, where they do feel like they should do this. They're very motivated to do this, but then they move through that stage and then become really identified and intrinsically motivated, and that in general they're just more motivated overall, right? They both are doing it for identified and more intrinsic reasons, but also because they feel like they should, and they would feel a bit guilty if they didn't. And so often with these types of behavior changes, we might start with these more controlled types of motivation, but then over time become more identified or more intrinsically motivated. And so that's one possibility here. But the key effect here is that we have more people who are identified and more people who are intrinsically motivated after this intervention. Then, we said they also were engaged in more steps per day, more physical activity, right? These are pretty large effect sizes, right? These are actually like real meaningful differences in levels of physical activity, and those again led to weight loss differences, and so you can see some of those numbers there. They're also in the paper you read, but again, 5.6 kilograms of fat loss versus gaining 1.5. Then we've got these different body fat numbers and BMI. And then we can just see this tracked here. This is the percent weight change over time. We've got it at baseline. Again, there was no differences. Then the intervention group at 4 months and the intervention group at 12 months. And we can see that that's obviously sloping downward. They're seeing a change in weight, whereas the control group, there's a little bit of a change, but not all that much, right? And it's significantly different than the intervention group. Don't worry about the difference between this BOCF versus the other lines. Just my guess is that's something that the reviewers asked them to do. Basically, it's a specific type of way of handling statistics where you account for missing data in a different way. And basically what they're showing here is it doesn't make a difference if you do it that special newfangled way. And so the effect is the same, and so you don't need to worry about that difference. But just if you were curious what that is. Then this crazy looking graph is just kind of a funny aside, is when I've taught this course before, I really mucked up and I didn't realize that there are actually two Silva et al. 2010 studies based on the exact same data set, and so I assigned one and then accidentally posted the other, and so because of that I have now discovered the other article. Again, exact same data set, but what they did in that was just take this same information. Again, this is a good example of how things have changed since 2010. Now I don't think you could get away with publishing two such similar studies, but they basically just put all of their variables together into a path model. And so we can see that what they're showing here is that being in the intervention versus the control condition, being in the intervention led to more need support overall, particularly more satisfaction of autonomy and more perceived competence around this weight loss behavior. And then this led to, this more competence led to, more introjected motivation, more identified and more intrinsic, and then that's what led to more exercise. This is more moderate and vigorous exercise, right? So it's basically just showing that, again, you don't need to worry about all the particular numbers on this, but what they're showing is that overall you can sort of map the treatment from the need support leading to the need satisfaction, leading to more of the good types of motivation and less of the bad types, with the weird exception of introjection here, and then that having an impact on people's healthy lifestyle. This is the diet part, and then more moderate and vigorous exercise. Right? So that's what we're showing here. And just to note, the effects of exercise are much stronger than with this lifestyle. They really play it up in the paper, but you can see that there really aren't any stars by these. But that's an aside. Don't worry too much about what this model's showing. I just wanted to note that if you did search for the article yourself and you found this one, that's not the one you're looking for. It's a different one. It's in the one you were assigned is the one in the Journal of Behavioral Medicine. And then just lastly, in this class, we're really focusing on the autonomy support and other need support of healthcare providers themselves, but it's also really worth noting that autonomy support can come from others as well, and this is really important for these long-term health behaviors that you have to engage in all the time in your everyday life, right? They really take place outside the doctor's office, right? So like engaging in exercise, right? Something I should be doing, regularly. And so this is just a clipping from a study that came out fairly recently that showed that autonomy support from people's partners, so their romantic partners, was a key determinant of having more autonomous motivation for exercise and for their well-being, and also led to more weight loss among women who were trying to lose weight. So this was particularly among women who started out overweight, and so just it's important to have autonomy support from not just your provider but from others in your life as well. I'm going to wrap that up there, and then we'll turn to talking about intrinsic versus extrinsic goals.